Coming to whether this we can modify Siewert's to improve the surgery better. Definitely we can. The modification is if we can take a little bit of lesser numbers as 3 centimeter as the cutoff margin of esophageal involvement, we can treat more than 3 centimeter esophageal involvement with Ivor-Lewis and treat it as esophageal malignancy. Less than 3 centimeter invasion with majorly gastric involvement is to be taken with total gastrectomy with or trans-hiatal, and if the Siewert 3, it should go for total gastrectomy, extended total gastrectomy. The Japanese have used the same criteria, and then they have come up with the recommendation as to what should be the mediastinal lymph node fields that are to be resected, what should be the surgical approach, what should be the abdominal lymph node dissection, and the type of gastrectomy that is to be included in GE junction tumors. Type 1, the upper, middle, and lower mediastinal lymph nodes are to be resected. The surgical approach is right thoracic, abdominal lymph nodes, 1, 3, 7, 19, and 20, and it is either a partial gastrectomy or a proximal gastrectomy. Coming to type 2, if the esophageal involvement is more than 3 centimeter, the mediastinal lymph nodes, depending on the extent of the tumor, upper, middle, and lower, right thoracic approach, lymph nodes, abdominal lymph nodes, and a partial gastrectomy or a proximal gastrectomy. Less than 3 centimeter, only the lower thoracic lymph nodes are resected. The approach should be trans-hiatal. And in type 3, it is the lower mediastinal lymph nodes to be resected en bloc, trans-hiatal approach, and the surgery would be either total gastrectomy or extended total gastrectomy. Can we improve the accuracy of Siewert's classification? In a retrospective study, they showed that when you combine both PET endoscopy and staging laparoscopy, we can improve the accuracy of Siewert's classification by up to 75%. Can we use Siewert's in neoadjuvant setting? Definitely we can. And it is also helps us compare pre and post neoadjuvant response to the neoadjuvant treatment. Can we combine molecular profiling in Siewert's? Yes, we can, especially in type 2 tumors, where we can assess the immune molecular subtype, whether it is immune inflamed, intermediate, or deserted, and depending on that, we can decide on the neoadjuvant protocol. This is just to tell immune. So, there are multiple studies which are going on. There is one trial, that is a CARDIA trial, which is ongoing, which can probably help us define better whether the type 2 tumor should undergo whether esophagectomy or gastrectomy. There are other classification systems for GE junction tumors. Majorly, it is AJCC system 8th edition, wherein they have divided based on epicenter. If it is less than 2 centimeter, it is into the gastric cardia, it is taken as esophageal. More than 2 centimeter into gastric cardia, taken as gastric malignancy. WHO again defines the tumors based on tumor cell morphology, adeno-CA or squamous cell, and if it is adeno-CA, Lauren has subclassified again into intestinal type and diffuse type. The Japanese have their own classification system. It is basically based on niches, but this also includes detailed classification on lymph node station mapping, and there is an emphasis given on D1 and D2 lymphadenectomy in type 3. These are some of the strengths and weaknesses of all these classification systems. And I would like to conclude that Siewert's classification aids for precise clinical decision making, Type 2 is the challenging one, which requires individual strategy as of now. We need to integrate imaging, staging, include multidisciplinary input, which includes surgeon, oncologist, radiologist, and pathologist for better optimization of treatment protocols. Thank you.